Today, let's see the topic on therapeutic nutrition in pancreatitis. To begin with, the pancreas is an elongated, flattened gland that lies in the upper abdomen behind the stomach, which is approximately 6 inches in length. This glandular organ has both endocrine and exocrine function. Pancreatic cells manufacture glucagon, insulin, and somatostatin for absorption into the bloodstream, mainly for endocrine function, for regulation of glucose homeostasis. Other cells secrete enzymes and other substances directly into the intestinal lumen, where they aid in digesting proteins, fats, and carbohydrates, which are exocrine in function. Factors that influence pancreatic secretion during a meal can be divided into 3 phases. The first phase, the cephalic phase, which is mediated through the vagus nerve and is initiated by the sight, smell, taste, and anticipation of food, and it leads to the secretion of bicarbonate and pancreatic enzymes. The next phase is gastric phase. Gastric distension with food initiates the gastric phase of pancreatic secretion, which stimulates enzyme secretion, and the third phase is the intestinal phase, which has the most potent effect on pancreatic secretions and is mediated by the release of cholecystokinin. Let's see the objectives. It's mainly to understand the causes and symptoms of pancreatitis and to learn about the therapeutic nutrition for recovery from pancreatitis. Pancreatitis is an inflammation of the pancreas and it is characterized by edema, cellular exudates, and fat necrosis. The disease can range from mild and self-limiting to severe, with autodigestion, necrosis, and hemorrhage of pancreatic tissues. This condition is categorized into acute and chronic pancreatitis, the latter with pancreatic destruction so extensive that exocrine and endocrine functions are severely diminished and maldigestion and diabetes may result. This is the criteria to classify the severity of pancreatitis. The symptoms of pancreatitis can range from continuous or intermittent pain of varying intensity from mild to severe upper abdominal pain, which may radiate to the back. Symptoms may worsen with the ingestion of food. Clinical presentation may also include nausea, vomiting, abdominal distension, and steatorrhea. Severe cases are complicated by hypotension, oliguria, and dyspnea. This may even lead to hemorrhage, shock, or death. The chronic pancreatitis patients are usually malnourished due to the deficient secretion of enzymes which require for the proper digestion and absorption of various nutrients. Next, let's see on the causes. Pancreatitis has numerous causes including chronic alcoholism, biliary tract disease, cholelithiasis, which is nothing but the formation of gallstone, certain drugs, trauma, hypertriglyceridemia, hypercalcemia, and some infections such as viruses. Whereas alcohol is a leading cause of chronic pancreatitis, gallstones are the most common cause of acute pancreatitis. It is associated with severe complications and significant mortality. Next cause is the hereditary. In certain cases, pancreatitis occurs in relation to inherited abnormalities of pancreas or intestine. Repeated acute pancreatitis attacks within the age of 30 years mostly progresses to chronic pancreatitis. The main cause of this progression is cystic fibrosis. Genetic testing is demonstrated as a valuable tool in assessing patients predisposed to hereditary pancreatitis. Similar to chronic pancreatitis, hereditary pancreatitis is also a progressive disease that has an increased risk of permanent problems. They may develop chronic pain, diarrhea, malnutrition, and diabetes mellitus. The therapy is focused on pain control and pancreatic enzyme replacement. Autoimmune disorder. The body's immune system acts against its own body, and blockage in the pancreatic or common bile duct may lead to pancreatitis. When two or more immediate members of the family have a history of pancreatitis, it may also increase the incidence. Genetics. The mutation of the trypsinogen gene causes hereditary pancreatitis, whereas the mutation of SPINK1 gene is linked to acute and chronic pancreatitis. Individuals with CFTR gene mutation that causes cystic fibrosis are predicted to have 40 to 80% greater risk of chronic pancreatitis. 10% of pancreatic cancers may be due to genetic factors. The exact mechanism that leads to pancreatic injury is not yet evident. One theory involves blockage or reflux of the ductal contents into the pancreatic duct. It appears that a common characteristic is premature activation of the enzymes within the pancreas, resulting in autodigestion within the pancreatic cells. The enzymes released by destroyed pancreatic cells eventually reach the bloodstream, causing elevated serum amylase and lipase level. Usually, a hallmark finding in acute pancreatitis, these markers alone are not always diagnostic, nor do they indicate the extent of pancreatic injury. Further evaluation of the extent or severity of pancreatic injury is best done with radiographic imaging studies. It should be noted that in cases of chronic pancreatitis involving extensive destruction of pancreatic tissues with subsequent fibrosis, enzyme production is diminished and serum amylase and lipase may appear normal. However, absence of enzymes to aid in digestion of food leads to steatorrhea and malabsorption. Next, let's see the medical nutrition therapy. First, acute pancreatitis. Acute pancreatitis, a serious condition of inflammation of pancreas within a short period of time. The recovery is mostly within a week with no further complications except in severe cases that can be fatal. This condition is more common in middle ages and elderly people, but can occur in all age groups. It is mostly alcohol related pancreatitis in men and gallstones related in women. Pain associated with pancreatitis is partially related to the secretory mechanisms of pancreatic enzymes and bile. The nutrition therapy is therefore adjusted to provide minimal stimulation of these symptoms. The pancreas is put at rest. During acute attacks, all oral feeding is withheld and hydration is maintained intravenously. The average patient with uncomplicated pancreatitis is free from pain, nausea and vomiting, usually within 2 to 3 days. In less severe attacks, a clear liquid diet with negligible fat may be given for a few days. The patient should be monitored for any symptoms of pain, nausea or vomiting. The diet should be progressed as tolerated to easily digested foods with a low fat content and then advanced as tolerated. Foods may be better tolerated if they are divided into 6 small meals. Severe acute pancreatitis results in a hypermetabolic and catabolic state. Induction of severe acute pancreatitis results in immediate metabolic alterations in the pancreas with rapid onset of metabolic disturbances not only in the local challenged organ but also in remote organs. Amino acids are released from muscle and used for gluconeogenesis. These patients often exhibit signs of malnutrition such as decreased serum levels of albumin, transferrin and lymphocytes. Attention should be given to nutrition regimen with adequate protein in an effort to achieve positive nitrogen balance. Energy expenditure has been shown to be up to 49% greater than predicted in these patients. Oral nutrition must be delayed even longer when acute illness persists longer than a few days with persistent or recurrent elevation of serum amylase, continued abdominal pain and ileus. It is also done when cessation of nasogastric suction is followed by return of symptoms, the presence of complication such as pancreatic abscess, pseudocyst or obstruction to the main pancreatic duct is suspected. In these severe prolonged cases, parenteral nutrition may be necessary. Patients with mild to moderate stress can tolerate dextrose-based solutions, whereas patients with more severe stress require a mixed fuel system of dextrose and lipid to avoid complications of glucose intolerance. Lipid emulsion should not be included in the parenteral nutrition regimen if hypertriglyceridemia is the cause of the pancreatitis. A serum triglyceride level should be obtained before parenteral nutrition with lipids is initiated. Lipids may be given to patients with triglyceride values less than 400 mg per dl. Because of the possibility of pancreatic endocrine abnormalities as well as relative insulin resistance, close glucose monitoring is also warranted. H2 receptor antagonist may be prescribed to decrease hydrochloric acid production, which will reduce the stimulation of the pancreas. Somatostatin is considered the best indicator of pancreatic secretion and may be added to the parenteral nutrition solution. Depressed serum calcium levels are often identified in patients with acute pancreatitis. Possible causes include hypoalbuminemia with subsequent third spacing of fluid. The calcium, which is bound to the albumin, is thus affected and may appear artificially low. Another possible explanation is a soap formation by the calcium and fatty acids created by the fat necrosis. Checking an ionized calcium level is a method of determining available calcium. Aggressive nutrition support may also include attempts to use location of the feeding, and the composition of the formula will determine the degree of pancreatic stimulation. Several prospective randomized trials have shown that enteral nutrition into the jejunum is well tolerated in acute pancreatitis. Close observation for patient's tolerance is very important. When patient is allowed to eat, supplemental pancreatic enzymes may be needed to treat steatorrhea. Next, let's see the chronic pancreatitis. In contrast to acute pancreatitis, chronic pancreatitis usually evolves insidiously over many years. Chronic pancreatitis is characterized by recurrent attacks of epigastric pain of long duration, and they may radiate into the back. The pain can be precipitated by meals. Associated nausea, vomiting or diarrhea makes it difficult to maintain adequate nutritional status. Patients with chronic pancreatitis are at increased risk of developing protein calorie malnutrition because of pancreatic insufficiency and inadequate oral intake resulting from postprandial pain. In a study, patients with chronic pancreatitis admitted to a tertiary care center were found to have a 90% incidence of malnutrition, including weight loss, deficits of lean muscle and adipose tissue, visceral protein depletion, and impaired immune function. The objective therapy for patients with chronic pancreatitis is to prevent further damage to the pancreas, decrease the number of attacks of acute inflammation, alleviate pain, decrease steatorrhea, and correct malnutrition. Dietary intake should be as liberal as possible, but modifications may be necessary to minimize symptoms. Substitution of dietary fat with medium chain triglyceride oil may release steatorrhea and lead to weight gain. Malabsorption of the fat soluble vitamins may occur in patients with significant steatorrhea. Also, deficiency of pancreatic protease necessary to cleave vitamin B12 from its carrier protein could potentially lead to vitamin B12 deficiency. With appropriate supplemental enzyme therapy, vitamin absorption should be improved. However, the patient should still be monitored periodically for vitamin deficiencies. Water-soluble forms of the fat-soluble vitamins or parenteral administration of vitamin B12 may be necessary. Because pancreatic bicarbonate secretion is frequently defective, medical management may also include maintenance of an optimal pH to facilitate enzyme activation. Antacids, H2 receptor antagonist, or proton pump inhibitors that reduce gastric acid secretion may be used to achieve this effect. In chronic cases with extensive pancreatic destruction, the insulin secreting capacity of pancreas decreases and glucose intolerance develops. The treatment with insulin and nutrition care similar to that used for a patient with diabetes mellitus is then required. Management is delicate and should focus on control of symptoms rather than normoglycemia as the goal. Effort should be made to cater to the patient's tolerances and preferences for nutrition management. However, alcohol is prohibited because of the possibility of exacerbating the pancreatic disease. There is evidence that the progressive destruction of the pancreas will be slowed in the alcoholic patient who abstains from alcohol. The first goal of medical nutrition therapy is to provide optimal nutrition support, and the second is to decrease pain by minimizing stimulation of the exocrine pancreas. Because cholecystokinin stimulates secretion from the exocrine pancreas, one approach is to decrease cholecystokinin levels. If postprandial pain is a limiting factor, alternative enteral therapies that minimally stimulate the pancreas are warranted. Nutritional counseling, antioxidants, and pancreatic enzymes may play a role in effective management of chronic pancreatitis as well. Idiopathic chronic pancreatitis is often associated with the cystic fibrosis, gene mutation, and therapies directed toward cystic fibrosis may benefit these patients. When pancreatic function is diminished by about 90%, the enzyme production and secretion are insufficient. Maldigestion and malabsorption of protein and fat thus becomes a problem. Large meals with high fat foods and alcohol should be avoided. The patients may present with weight loss despite adequate energy intake and will also give a history of bulky, greasy stools. Pancreatic enzyme replacement is mandatory at this time. The pancreatic enzyme replacements are given orally with meals. The dosage should be at least 30,000 IU lipase with each meal. To promote weight gain, the level of fat in the diet should be the maximum a patient can tolerate without increased steatorrhea or pain. Additional therapies that tries to maintain nutritional status and minimize symptoms in patients with maximal enzyme supplementation include a lower fat diet with 40 to 60 grams per day, or substitution of some dietary fat with medium chain triglycerides oil to improve the fat absorption and weight gain. Meals should be small and frequent. Next, let's see the nutritional management for acute pancreatitis. Mainly, the first is to withhold the oral and enteral feeding, support with IV fluids. If oral nutrition cannot be initiated in 5 to 7 days, nutrition support can be started. For less severe cases of prolonged acute pancreatitis, tube feeding can be initiated using a defined formula diet. For severe acute pancreatitis, parenteral nutrition should be initiated. If triglycerides are less than 400 mg per 100 ml before parenteral nutrition initiation, 3-in-1 solution is used and triglyceride levels are monitored. If triglycerides are elevated more than 400 mg, dextrose based solution is used. Serum glucose is monitored frequently and treated as needed with insulin. Once oral nutrition is started, the following can be provided, mainly the easily digestible foods, low fat diet, 6 small meals, adequate protein intake and increased calories. Next, let's see the chronic pancreatitis. For this, the provision of oral diet is very important in the acute phase. Tube feeding can be used when oral diet is inadequate, and supplement pancreatic enzymes whenever required, along with the supplements of fat soluble vitamins and vitamin B12. Next, let's move on to the dietary guidelines. Dietary guidelines involve foods rich in B vitamins and iron rich such as whole grains, dark green leafy vegetables. To restrict the refined foods such as sugar and refined wheat flour products. To include antioxidants rich foods such as cherries, grapes, tomatoes, etc. To reduce the consumption of red meat and include more lean meat or depend on pulse for protein. To avoid trans fatty foods, especially the bakery products. Then use of cooking oil, mainly coconut oil, olive oil or gingerly oil, and to restrict the alcohol, coffee, tobacco and other stimulants. The food must be bland, soft and well cooked. Increased fluid intake of 6 to 8 glasses of purified water per day, and moderate exercise for 30 minutes per day and 5 days a week is recommended. Now, let's move on to the foods to be included. Whole grains, cereals, fruits, leafy vegetables and peppers, low in fiber, olive oil and coconut oil could be used. And the foods to be avoided are the bakery products, avocado, high fat dairy products, alcoholic beverages, red meat, fried foods, butter, spices, simple sugars, preserved or canned foods and white flour. To summarize, pancreatitis is an inflammation of the pancreas and is characterized by edema, cellular exudates and fat necrosis, which ranges from acute to chronic condition. A diet, mainly clear fluid diet in the initial stages are given, 6 small meals to be given, low fat, low fiber, increased calorie and protein diet rich in antioxidant with restriction of alcohol is recommended with parenteral feeding in severe condition.